Good evening, everybody. So this is our remarkable rapid revision 2.0, especially for FMG students by Dr. Bhanu Prakash. Today I'm here with your Biochem subject, which appears boring to you, but it is quite interesting if you do with concepts, right? Okay, so I have selected these last 11 papers, 2019 to 2025. I have On one slide, I'll be telling you the topics which are frequently asked in these last 11 exams, in the last 11 papers, around 5 years of your last FMG exams. So, diseases. The first thing which I have placed here is diseases, okay? So, amino acid disorders, Alkaptonuria. You know, Alkaptonuria is most common amino acid disorder. Most common is phenylketonuria. Alkaptonuria is also quite common to ask in exam. Then MSUD, G6PD enzyme deficiency, von Gog's disease, a glycogen storage disease, also McArdle's a glycogen storage disease. Then PDH deficiency, the enzyme of link reaction, Lish-Nyhan syndrome, xeroderma pigmentosa, DNA repair defect, HNPCC, Hartnupp's disease, cystinuria, homocystinuria, and albinism. So all these topics which I'm gonna tell on this page, these are the topics of your FMG rapid revision program. You must do these topics in Biochem before going for exam, right? So then next is galactosemias are very frequently asked, very important. Sphingolipidosis, most common is Gaucher's disease. Then the concept of sorbitol and diabetes is frequently asked because pharma industry is working on the drugs which are having metabolism with sorbitol, right? Then MCD deficiency, then kwashiorkor, hyperammonemia and urea cycle frequently asked, then hyperlipidemias type 1, 2, 3, then Zellweger syndrome frequently asked, orotic aciduria from pyrimidines, then vacutainers colors. Recently they have started asking the colors of vacutainers. So please do it, just one slide. Then amino acids and the products are frequently asked, okay, especially tyrosine, arginine, homocysteine. Then essential fatty acids, linoleic, linolenic. Then vitamins which are frequently asked are B1 and B3 are most common, right? Wernicke encephalopathy which occurs due to B1 deficiency, especially in alcoholics. Then B6, B9 folic acid, B12, then fat soluble or fat soluble A, K, E, and D. Okay. Then minerals which are frequently asked. Calcium, fluorosis is frequently asked. For copper, we have two diseases, Menke and Wilson. Then iron, selenium, Cation disease. Okay. Then RNA editing is the new topic which you should do, right? Then we have zinc and carbonic anhydrase, then collagen, ETC and diabetes, enzyme inhibition graphs. Okay, then coming to cofactor and coenzymes, GLUTs, glucose transporters, carbon monoxide poisoning, nitric oxide, gluconeogenesis, the structure of DNA, which is very simple, but little tricky. Okay, so do solve questions on that. Then ammonia transport, right? Then reverse transcriptase enzyme, the favorite of examiners. Chaperon, just one or two lines about chaperon that they give shape to the proteins, right? Then lactose intolerance, frequently asked, sickle cell mutation, glycemic index of food, then pathways which occur in cytoplasm and mitochondria. Then GAGs, especially hyaluronic acid, heparin, and keratin sulfate are asked. Then inhibitor of glycolysis, especially sodium fluoride, which inhibit enzyme enolase and is used in the gray vacutainer for glucose estimation. Then you should be very clear about NAD, FAD, and especially NADP. The nitrogenous bases, purines and pyrimidines, ETC, inhibitors and uncouplers. In ETC, just these two things are required, inhibitors and couplers, that's it. Yes, dear Dr. Roshni, first year students can also watch this because I always teach conceptually, whether even if it is rapid revision, I will never tell students to cram. Things are very easy and conceptual in Biochem. Yeah, it is possible. I know you're hearing this for first time maybe. Yeah, we expect around 12 to 15 questions from Biochem. And once you do Biochem conceptually, it helps you in a little bit in pharma and a lot in medicine also. So it's a basic subject you must do. Then markers of vitamin deficiency, very important. Then purine catabolism, in which we have xanthine oxidase pathway, enzyme rate limiting, right? Xanthine oxidase. Then lipoproteins. Lipoproteins are very important, HDL, LDL, VLDL. Then VMA and catecholamines, gluconeogenesis, protein structure, right? These are frequently asked. So let's start with our topics now. So Pellagra question is almost there in every exam. So Pellagra occurs because of B3 deficiency, right? Vitamin B3, that is niacin deficiency. We all know, right? Very easy, niacin or vitamin B3 deficiency leads to pellagra. Now, this vitamin B3 is an atypical vitamin. Atypical vitamin means that which can be synthesized. I hope my speed is okay. So, it can be synthesized in body. I'm not talking of the enzyme vitamins which are synthesized from the intestinal bacterial flora. No, I am talking of like human body can synthesize them. So they are atypical. We have two atypical vitamins, that is B3 and vitamin D. You all know vitamin D can be synthesized from sunlight. And what about vitamin B3? It is synthesized from which amino acid? Can anyone tell me? Vitamin B3 or niacin is synthesized from amino acid tryptophan. Tryptophan is an essential amino acid. Okay, essential amino acid means it is coming from diet. So from diet we take tryptophan, and then in body there's a big complex pathway via which tryptophan gets converted to vitamin B3. 60 milligram tryptophan will be used to make just little bit 1 milligram of niacin, right? And during this pathway, vitamin B2 and B6 are used. Okay, very important basic reaction which I have given you in the shortest possible form, but all your concepts come in here, that vitamin B3 is an atypical vitamin because it can be synthesized in body. Otherwise, the definition of vitamin is a thing which cannot be synthesized in body, right? So from diet we get tryptophan, and then from tryptophan vitamin B3 is formed. During this big pathway, two more B complex vitamins are required, that is vitamin B2 and B6. So if B2 or B6 is deficient, can I say that B3 deficiency will occur or pellagra will occur? Okay. So this you need to learn. 60 milligram tryptophan makes 1 milligram niacin, right? So on this one slide, see, I have put a lot of efforts in making this PowerPoint presentation. A lot of comparisons you will find on a single slide. If you revise this slide, these slides, it will be very useful. My sequence is well planned. My each and every page is well planned. It will help you learn. It will help you compare. So on this one page example in this slide, I will be teaching you the sign and symptoms of pellagra also and the causes of pellagra also. These both things are frequently asked. Okay. Yeah, you can see the image. In the image, you can see the dryness on the skin, especially the sun exposed areas, the forearms, elbow, and the below knee legs. So it is photosensitive dermatitis, and this picture shows Casel's necklace, right? Necklace kind of appearance in for the dermatitis, right? So there are 6 Ds we say these days. Earlier there were 3 or 4 Ds of pellagra. Now we have 6 Ds of pellagra. So first 3 are, my sequence well planned, delirium, dementia, depression, all affecting brain. Okay. So delirium, dementia, depression. Then we have dermatitis. I told you, photosensitive dermatitis. Then diarrhea, and the last D for death. Okay. So I hope you're able to learn from the sequence. I am again repeating my sequence well planned to help you learn. Then coming to the causes of pellagra. Causes. See, I told you B2 and B6 are required for making B3. So B2 or B6 deficiency will also lead to pellagra. Isoniazid is an anti-tubercular drug, we all know. It inhibits B6 formation, that is the active form of B6, PLP, pyridoxal phosphate. So if this will inhibit B6 formation, so obviously it will lead to pellagra. Then high corn or maize diet as a staple diet. Because this diet, this corn has a protein zein, and zein protein lacks tryptophan. So tryptophan deficiency will also lead to this niacin deficiency. Then jowar diet or sorghum, it has excess of leucine, which inhibits QPRTase. It is a rate limiting enzyme for formation of B3 from tryptophan. Rate limiting enzyme is QPRTase. These days, they are not asking the pure biochemistry, rate limiting enzymes, or the chemistry part of it. They are more asking for the diseases. The clinical biochemistry is more frequently asked. So, you should always, when you're studying the subject, you should always focus on the clinical part of it. Especially the pattern is shifting towards USMLE type, right? So, carcinoid syndrome, in which lot of tryptophan is used to make serotonin. So when a lot of tryptophan is used to make serotonin, then there is deficiency of tryptophan leading to deficiency of niacin. Okay, then is Hartnupp's disease. In Hartnupp's disease, tryptophan lost in urine. Tryptophan lost in urine, right? So these are all the causes of pellagra. B2 or B6 deficiency, then isoniazid, then so these first two factors where B2 or B6 is affected. Then next two factors of diet, high corn diet or jowar diet, right? Then next two diseases, carcinoid syndrome, Hartnupp's disease. Okay, so my sequence is well planned. If even if you are cramming the sequence, you have understood also. Even if you are cramming, then also it will help you. The sequence will help you, right? Okay, coming to my next slide. So be very careful. If the question, they give you a big question, clinical case history, and the main pointers which you have picked from the question is dermatitis and diarrhea. Now, many students will do this mistake of quickly going to the diagnosis of pellagra. But be careful. You have to do the differential diagnosis with zinc deficiency because in zinc deficiency also, you remember that there is dermatitis and diarrhea and zinc deficiency also. Now you need to see the differences so that if the question is trying to confuse you between these two, you are able to make the correct choice, right? And don't fall into the prey of the examiner, right? Okay. So in case of pellagra, I have shown the picture of Kazel's necklace. That is so very specific, right? Now there is photosensitive dermatitis. CNS is involved with delirium, dementia, and depression, right? I told you. So one point is CNS involved and one point is especially photosensitive dermatitis is there. Coming to zinc deficiency. In zinc deficiency, especially you will look for dermatitis is there, but it's a different type of dermatitis. It's not in the sun exposed areas. In fact, it's in the perioral region, like inflammation around nose, mouth, cheeks, elbow, anus, private parts. There is delayed wound healing if given in the question. It is very going towards zinc deficiency as our diagnosis. Then alopecia also, right? So be careful. Whenever a question says dermatitis and diarrhea, you should read the question very carefully and check whether it is pellagra question or it is zinc deficiency question. And it is easy to check this, easy to come to the right choice if you do the slide. Okay, coming to, so that was zinc deficiency in children, which was shown here on this slide, has written that it is known as ectodermatitis enteropathica. Enteropathica. Okay. Then we can also read about The sign and symptoms of zinc deficiency in adults. This question was asked in INICT May 24. So patient has loss of smell and taste, insulin resistance, sexual maturation defect and hypogonadism, because zinc is required for androgen formation. Okay, very important point. Then diarrhea, dermatitis, delayed wound healing and alopecia. This I already told you in the previous slide, right? And also recurrent infections, right? Coming to the next slide, there are two water-soluble vitamins which cause toxicity. Otherwise, water-soluble vitamins are, if they are in excess, they are lost in urine because they are soluble in water, they will be going out. But you need to be careful. There are two water-soluble vitamins which cause toxicity, right? So coming to B3 toxicity or B6 toxicity. So in B3 toxicity, patient has macular edema, macular cyst, liver is affected, hepatic toxicity occurs, hyperuricemia, and also patient has GI symptoms and impaired glucose tolerance. B6 toxicity, sensory neuropathy, seizures. So brain is affected here in B6, seizures, also photosensitivity, and GI symptoms and impaired glucose intolerance are common features for both B3 and B6. Okay. Now coming to the next very important point, frequently asked, causes of B1 deficiency. So diet primarily rich in polished rice. If polished rice word written in the question, you can quickly go for B1 deficiency or any processed grain because the outer aileron layer of grains contained is rich in vitamin B1. If processed grains are used, then B1 deficiency will occur. Okay. Then parenteral nutrition without adequate B1 supplementation. So next is chronic use of diuretics, because with diuretics, vitamin B1 is lost in urine. Then prolonged diarrhea, vitamin B1 will be lost. Chronic alcoholism, alcohol is anti with B1. Okay, whenever chronic alcoholism or alcoholic patient given, mostly the question is on B1 deficiency, right? Then hyperthyroidism, chronic kidney disease. So be careful, B12 deficiency is a common complication after gastrectomy, right? And veganism will lead to B12 deficiency. Then coming to beriberi, B1 deficiency beriberi, it is of two types, wet and dry. In wet, cardiovascular system is affected, so patient has edema, so swelling of legs, shortness of breath and increased heart rate. In dry beriberi, nervous system will be affected. Patient will be having difficulty in walking, numbness in hands and feet, confusion, pain and vomiting. Coming to this Wernicke-Korsakoff syndrome, it has two components. One is Wernicke, which is the encephalopathy. Other is Korsakoff, which is the chronic amnesic syndrome. So Wernicke, so these two are not different conditions, but different stage of the same disease. So Wernicke is acute and Korsakoff is chronic. So Wernicke, an acute, reversible, but life-threatening condition. So it is acute, reversible, but life-threatening. Then it's Wernicke encephalopathy has a classic triad of ACO, ataxia, confusion, and ophthalmoplegia. Do remember this triad of ACO? Then Korsakoff represents the disorder progressing to the, I told you, chronic or long-lasting stage. It's a memory disorder, right? Amnesia, right? So again, this one slide. So it's about B1, both wet and dry. Very easy. Wet very affects CVS, dry will affect CNS. And Wernicke and Korsakoff are two components when especially occurring in alcoholic patients. So B1 deficiency is very common in alcoholic patients because alcohol affects the absorption of B1. Plus, these patients are not eating healthy, so they're not taking a vitamin-rich diet. So diseases. I'm going to give you the category of diseases, all the categories here. Lysosomal storage diseases, then protein targeting disorders, Garrod's tetrad, glycogen storage diseases, amino acid transporter defects, then glycine disorders, then the amino acid disorders, galactose and fructose. Okay, so first we'll be taking all of them one by one. First is lysosomal storage diseases. These are mucopolysaccharidosis, eye cell disease, Pompe's disease, sphingolipidosis, Wolman's disease, cystinosis. So these are the lysosomal storage diseases, which we'll be doing them one by one. So first is mucopolysaccharidosis, in which mucopolysaccharides will accumulate, right? So there is, see this picture, a typical case of a mucopolysaccharidosis patient. Short stature, from this small image only you can guess short stature. Patients have corneal clouding and they have vision abnormalities. So you can see this person is wearing spectacles. Coarse facial features, mental retardation. So many points are clear from this image. Very nice image. If you remember this, you can remember all these clinical features. This patient has hepatosplenomegaly, clawing of hands. See the clawing of hands, claw-like hands. Bullet-shaped middle phalanx in the X-ray. Bullet-shaped middle phalanx. Okay. So we have type 1 mucopolysaccharidosis, that is Hurler disease. Then we have type 2 Hunter disease. Only these two are important, Hurler and Hunter. In your books, 5-6 types are given. See, it takes a lot of time in cramming all of them and remembering all of them, and then you forget everything in the exam. It's better to do little, but whatever you're doing, do multiple revisions of that. At least you should remember whatever you have read. Okay, instead of doing a lot, do the qualitative thing, right? Not the quantity for your all the entrance exams. Okay, yeah. So Hurler type 1 enzyme is starting from A alpha L iduronidase. Okay. Corneal clouding is present in these patients. Dermatan sulfate and heparin sulfate accumulation occurs in the body. It is autosomal. Most of your biochemistry diseases are autosomal recessive. And this type 1 is more severe disease. In type 1, Rayleigh body inclusions and inguinal hernia present. Okay. Now coming to Hunter disease type 2, enzyme you have to cram, iduronate sulfatase. Now very important point, corneal clouding is absent, so these patients have clear vision. You can see the picture, coarse facial features, short height, but eyes are clear. Okay. Then this point is same, dermatan sulfate, heparin sulfate accumulation. Now this is X-linked recessive. Hunter type 2 is X-linked recessive, so mostly affecting male patient. So can you see the relate with the name Hunter? Hunter is a person, usually male person, who is aggressive, right? And any hunter should be having a clear vision, right? Any aggressive person will kill others, okay? Do the hunting. So it will help you learn so many points. Male patient or male person for hunting, so X-linked recessive, because they are hunters, so they have clear vision, so no corneal clouding. And this is known as mild hurler with aggressive behavior. Okay, hurler was more severe. Hunter is mild with aggressive behavior. So hunters are aggressive. And Rayleigh body and inguinal hernias usually not found. So it is very easy if you know the slide and the previous slide of the clinical features, general clinical features of mucopolysaccharidosis, then you can solve any question which is frequently given in the Q banks of all Biochem, be it any place, be it any book, any app, and you will be able to solve the question. So you can have a look at the Rayleigh body inclusions. These are actually coarse purple granules which are filled with the undigested GAG, that is the dermatan sulfate or heparin sulfate. And these granules are surrounded by a clear zone. Okay, so you can see this in the neutrophil mainly. So these are Rayleigh body inclusions. Then coming to, so we are done with mucopolysaccharidosis. Coming to eye cell disease, that is inclusion body disease. Inclusion body disease. Here there is defect in Golgi apparatus. There is defect in Golgi apparatus, although it is a lysosomal storage disease, but the defect is in Golgi apparatus. The enzyme affected is this N-acetyl glucosamine phosphotransferase. Yes, you need to cram this name of enzyme. You can do it. Little bit cramming you can do. Mostly Bichem is conceptual. So yeah, this is NAGP transferase. You can say in short NAGP transferase. Okay. And this is a clinical features are same as mucopolysaccharidosis. Clinical features same as mucopolysaccharidosis, but more severe. More severe. Then coming to Pompe's disease, which is glycogen storage disease type 2. Glycogen storage disease type 2. Patient has hypotonia. Usually the clinical case will be a floppy child, hypotonic child, a floppy child. Okay, cardiomegaly. So this is only glycogen storage disease where heart is affected. Otherwise, in glycogen storage diseases, muscles and liver are affected. Here, heart is affected and liver is already obviously affected, hepatomegaly. Coming back to this slide, where all the lysosomal storage disease list I have given you, MPS, I-cell disease, Pompe's, sphingolipidosis, Wolman, and cystinosis, right? Okay, next coming to sphingolipidosis. First, see this chart of sphingolipidosis. Let me take the highlighter. So sphingosine alcohol, if you add one fatty acid in sphingosine alcohol, we get ceramide. In ceramide, if you add phosphate and choline, we get sphingomyelin. If on the other hand, we add glucose or galactose, it is cerebroside. You add oligosaccharide chain, we get gloposide. If we add salicylic acid or NANA, it is a ganglioside. Okay, so gangliosides are never present in liver, right? And the glucoform is never found in CNS. Glucoform is never found in CNS. So now we'll do the sphingolipidosis. Till now, I have told you the sphingolipids on this slide. Okay, sphingomyelin. If sphingomyelin accumulate, the disease is Niemann-Pick disease. So obviously the enzyme which is not working is sphingomyelinase. Means sphingomyelinase is not there to break down sphingomyelin. So sphingomyelin accumulates. So this is Niemann-Pick disease, right? Then if ceramide accumulates, it is Farber disease. Enzyme is easy. Ceraminidase, which was breaking down ceramide. Ceraminidase. Then glucose. If glucose is glucoform is getting accumulated, then it is Gaucher's disease, which is most common lysosomal storage disease. The enzyme is beta-glucosyl ceramidase. For galacto, there are two diseases, Krabbe's and Fabry's. This Fabry's with a Y. Okay. Krabbe's beta-galactoenzyme is deficient. In Fabry's, alpha-galactoenzyme is deficient. Okay, easy to learn. Gaucher's beta-glucoenzyme is deficient. Krabbe's beta-galactoenzyme is deficient. Fabry's alpha-galactoenzyme is deficient. So then is globosides. If globosides and ganglioside both accumulate, it is Sandhoff disease. Hexosaminidase A and B both are deficient. Then if ganglioside accumulates, it is Tay-Sachs disease. Only A type enzyme, hexosaminidase A, is deficient. Okay. So we have done 1, 2, 3, 4, 5, 6 diseases here, and only these 6 sphingolipidosis are enough. So Niemann-Pick disease, Fabry's and Farber disease, Gaucher's, Krabbe's, Sandhoff, and Tay-Sachs disease. So tell me one thing. I told you that gangliosides are never present in liver. Glucoform is never found in CNS. So tell me, if I tell you one line, all these sphingolipidosis, which I've mentioned on this page, they all have hepatomegaly. They have liver enlarged, except, so no hepatosplenomegaly in Tay-Sachs and no mental retardation in Gaucher's. As I told you, glucocerebroside is not found in CNS. Then Fabry's is the only one which is X-linked recessive. All others are autosomal recessive. Right? Then cherry red spot. This cherry red spot is present in all except the mnemonic is KGF. In sphingolipidosis, that all sphingolipidosis have cherry red spot except KGF. K is Krabbe's, G is Gaucher's, and Fabry. F is Fabry. Do remember it is Fabry with a Y, not Farber. Okay, so all sphingolipidosis have cherry red spot except KGF. Then you must remember, if angiokeratoma is given in a question of sphingolipidosis, it is Fabry's disease. Also, Fabry's resembles sickle cell crisis. Then the sphingolipidosis which resemble the rheumatoid arthritis kind of picture, that is Farber disease. Okay, so trust me, students, the thing of sphingolipidosis is so easy for you. This slide of sphingolipidosis, the sphingolipids and the diseases, you get a lot of information on this slide. Then few exceptions, just 5-6 exceptions, 1 2 3 6 exceptions on this page, or some pointers on this page, and you can solve any question on sphingolipidosis. There's no need to read the boring theory of books. Yeah, so sphingolipidosis thing made easy for you. Yeah. One more slide, because Gaucher's disease is the most common lysosomal storage disease because of all the lysosomal storage disease. Not only most common sphingolipidosis, it is most common lysosomal storage disease. So the enzyme I already told you, beta glucoform, right? It can be beta glucocerebrosidase or it can be called beta glucosyl ceramidase. Patient has hepatosplenomegaly. There's no mental retardation, no cherry red spot. I already told you. So, patient has hepatosplenomegaly, bony pain and pathological fractures, pancytopenia, thrombocytopenia, easy bruisability. Patients have easy bruisability. X-ray long bone picture has a typical Erlenmeyer flask deformity. Ends of long bones are expanding. The ends of long bones are expanding and lytic. Okay. Okay, Gaucher's disease, X-ray long bones, Erlenmeyer flask deformity, which is typical. No mental retardation, no cherry red spot. Enzyme replacement therapy, which is available, is acid glucosidase, emiglucerase, or velaglucerase alpha. And very characteristic crumpled tissue paper appearance of the Gaucher cell. Okay, tissue paper appearance. Then coming to next lysosomal storage disease, that is Wolman's disease. Typical feature is calcification of adrenals. It's a lysosomal storage disease, but not a sphingolipidosis. Be careful, it's not a sphingolipidosis. Enzyme is acid lipase. In Pompe's disease, the enzyme is acid maltase. In Wolman, enzyme is acid lipase. Wolman's disease, watery green diarrhea, vomiting, failure to thrive, hepatosplenomegaly. And it is also known as cholesterol ester storage disease. Cholesterol ester and triglycerides accumulate here. Then coming to cystinosis. Cystinosis is defect in cystine transporters. Defect in cystine transporter. It is not very important, but it's a lysosomal storage disease. Then coming to amino acid transporter defect. Okay, in cystinosis, the treatment is cysteamine, which chelates cystine, right? Then coming to amino acid transporter defect, the most common is cysteine urea. Cysteine urea. Which amino acid is excreted in urine? We learn from the mnemonic COL or COLA. C for cysteine in urine, O for ornithine, A for arginine, L for lysine. Okay, COL, C for cysteine. It's cysteine urea, not cystine urea. It is cysteine urea. O for ornithine, A for arginine, lysine. Then Hartnupp's disease, tryptophan coming in urine. That's why patient has pellagra. Glycinuria, very simple, glycine coming in urine. Then on next slide, two diseases taken deliberately on one slide, Refsum and Zellweger, because sometimes we can get confused about these two. So in Refsum, there is defect in alpha oxidation. Alpha oxidation defect. So enzyme is alpha oxidase, phytanic acid alpha oxidase, or phytanoyl-CoA alpha hydroxylase. Alpha oxidation occurs in peroxisomes. Clinical features of Refsum are cardiac arrhythmia, retinitis pigmentosa, peripheral neuropathy, anosmia, deafness, ichthyosis, ataxia. So basically heart, eyes and CNS affected. Zellweger, peroxisomes are defective. peroxisomes do not have their enzymes at all. They're like empty peroxisomes, also called ghost peroxisomes. Patient has upslanting eyes, high forehead, and there are skin folds along the nasal borders, right? So here cerebro, hepato, and renal are affected. So it's called cerebro-hepato-renal syndrome. So in Refsum's, alpha oxidation is affected, phytanic acid accumulates. In Zellweger, peroxisomes are affected. So in peroxisomes, alpha oxidation occurs and oxidation of very long chain fatty acid occurs. That is more than 20 carbon. So because alpha oxidation will not occur, so phytanic acid will accumulate. Also, very long chain fatty acid will accumulate. So I repeat, in Refsum, only phytanic acid will accumulate. In Zellweger, phytanic acid and very long chain fatty acid will accumulate. Okay. Then coming to Garrod's tetrad. Garrod's tetrad, 4 diseases. The mnemonic is CAAP. CAAP. C for cysteinuria. I told you cola mnemonic. Amino acid coming in urine. Hexagonal crystals are there in the urine. Then A, there are two A. One is Alkaptonuria. Other is albinism. P is pentosuria. Okay, these are the 4 diseases of Garrod's tetrad, frequently asked. Then glycogen storage diseases. If it's a liver glycogen storage disease, clinical feature is hypoglycemia, right? If it's a muscle glycogen storage disease, then muscle cramp or exercise intolerance, pain in muscles, right? Very simple. So this is a chart of glycogen. Left side glycogenesis, synthesis from glucose to glycogen. Rate limiting enzyme is glycogen synthase. Branching enzyme will make alpha 1,6 bond. On the other hand, breakdown of glycogen to glucose, that is glycogenolysis. Rate limiting enzyme, glycogen phosphorylase, which will break alpha 1,4 bond. Debranching enzyme breaks alpha 1,6 bond. Okay. Let's see diseases here also on this slide. Type 1 von Gog's disease, enzyme deficient glucose 6 phosphatase. Type 2 Pompe's acid maltase. Type 3 debranching enzyme deficiency, Cori's or Forbes disease. Type 4 Anderson branching enzyme deficient. 5 and 6 McArdle's and hers glycogen phosphorylase is affected, respectively in muscle and liver. Now, this one slide of glycogen storage disease with the help of which you can solve so many questions which are there in your Q banks or in your PYQs, right? So let's start this slide. Type 1 von Gog's enzyme is glucose 6 phosphatase. So glucose 6 phosphate will accumulate only in liver because this enzyme is present only in liver, right? Patient has severe hypoglycemia. Very characteristic point, severe hypoglycemia in von Gog's disease. Then is Pompe's, which is a lysosomal storage disease, enzyme acid maltase. Then type 3 Cori's. Third alphabet is C, A, B, C. So C, Cori's. D, debranching. Fourth is A for Anderson, B for branching. So C, D, A, B, easy to remember. Cori's, also called limit dextrinosis, debranching enzyme. Anderson or amylopectinosis, branching enzyme. So Cori's limit dextrins accumulate. In Anderson, amylopectins accumulate. Yeah. Dr. Altaf, A, B, C, D. Yeah. In these three, type 2, 3 and 4, liver, muscle, brain, all organs where glycogen is stored, they are affected. type 2, 3, 4. So if a question on glycogen storage disease, they say liver, muscle, brain affected, then you will say it is Pompe's or Cori's or Anderson. If if they have given in the question lysosome affected, then Pompe's. If in the question they have given limit dextrins, then Cori's. If in this question they have given amylopectins are found, then Anderson. Very easy to differential diagnosis of these three. Now, in Pompe's, you should learn the name of enzyme acid maltase. Another name is lysosomal acid alpha glucosidase. Recently, question was asked on Pompe's and this other name was written in the option. Type 3, glycogen is accumulated with short outer branches. Limit dextrin, limit, it has a limited growth, so short outer branches. Okay. Amylopectin is a kind of glycogen with very long outer branches. Okay. Coming to type 5 McArdles, which is most common in adults. Most common glycogen storage disease of adults is McArdles. Most common in children is von Gogh's. The enzyme of McArdle's muscle phosphorylase, organ affected only muscle. Characteristic feature, which is always given in a question of McArdle's disease, lactate not increased after exercise. Okay. Type 6 Hertz disease, liver phosphorylase, only liver affected. Patient has mild hypoglycemia. Also note, in type 1, if glucagon hormone is given, glucagon hormone will raise blood glucose. Blood glucose will not increase after glucagon hormone. Type 3, if glucagon given in fed state, then it will raise blood glucose. But if glucagon given in fasting state, it will not raise blood glucose. There is no need to do any other type, only these 6 types are important. Most of your questions are from this only. Especially FMGE exam, there's no need to do any other rare type. This is enough. Von Gogh's, because it is most common in children, so frequently asked, patient has hyperlipidemia, a lot of fat deposition, so round face, doll-like or moon-like face, very typical point written in the questions. Round doll or moon-like face. Severe hypoglycemia, so ketosis occurs. Then hepatomegaly, which is massive hepatomegaly. Kidneys are also enlarged, but spleen is not enlarged. In these patients, do remember, spleen is not enlarged. Liver and kidney enlarged. Then lactic acidosis, hyperuricemia. So these are very typical clinical features of von Gogh's disease, frequently asked. Coming to next slide. Again, a concentrated slide. Glycine. There are 3 diseases for glycine. Just read it once. Okay. It is very easy. Don't get scared. Okay. I'll help you understand this. Okay. Glycine. One is hyperoxaluria, also called primary hyperoxaluria. Defect, just cram the enzyme, glycine transaminase. Now understand the clinical feature. The name says hyperoxaluria. So increase oxalate in urine. Okay. Also oxalate is increased in any other part of body also. In kidney also. So there are extra renal oxalate deposits also and renal oxalate stones also. So everywhere in body there is oxalate, high in body, in kidneys, oxalate stones, extra renal oxalate deposits and oxalate in urine. Okay, because there's excess in body, so it is coming in urine also. Then glycinuria. So it's a transporter defect. Earlier also I told you there are 3 transporter defects for amino acids. One is glycinuria. So the name says glycine in urine. So increase glycine in urine. These patients also have risk of oxalate stones. So if a question says oxalate stones, it can be glycinuria or it can be hyperoxaluria. Then how will you distinguish? If urine oxalate is normal, it is glycinuria. If urine oxalate is increased, it is hyperoxaluria. So be careful if a question on oxalate stone, then check whether it is hyperoxaluria or it is glycinuria. Okay, by checking urine oxalate. If urine oxalate normal, then glycinuria. If urine oxalate increased, then hyperoxaluria. The name is telling you a lot of things, okay? But if you psychologically get scared of a content, then nobody can help you. But with the support of a teacher, you can slowly understand the thing, and then it will be an asset for you to revise when you revise. Okay, the third in glycine disorder is non-ketotic hyperglycinemia. Emia means blood, so there's increased glycine in blood, serum. Because it is increased in blood, it is coming in urine also. It is going to be raised in CSF also, right? The defect is in glycine cleavage system. Brain is affected, patient has mental retardation and seizures. So these patients have glycine encephalopathy. Because of excess glycine, this brain is affected. Okay. Then coming to phenylketonuria. Phenylketonuria. The problem is amino acid phenylalanine normally gets converted to tyrosine amino acid by enzyme phenylalanine hydroxylase, and this enzyme is not working in phenylketonuria. So tyrosine product is not formed. The substrate phenylalanine is accumulated. Normally tyrosine makes melanin pigment, it makes thyroid hormones, it makes catecholamines. So when melanin is not formed, then patient has hypopigmentation, fair skin, light color of hair, blonde hair. Most of your biochemical disorders are autosomal recessive. If anything which is not autosomal recessive, that I will tell you. When tyrosine is not there, thyroid and catecholamines are not formed, then a lot of deficiency of neurotransmitters in brain occurs, leading to mental retardation. There's severe mental retardation in the patients of phenylketonuria. Okay, hyperpigmentation and mental retardation. Now, phenylalanine is accumulated. Because of this, it will form phenyl acetate. It will give mousy, musty odor, very typical of phenylketonuria patients, mousy, musty odor. Then in diagnosis, ferric chloride urine test is positive. Best investigation is mass spectrometry. Mass spectrometry. In treatment, we restrict phenylalanine because that is in excess. Restrict phenylalanine. Give tyrosine, tryptophan. Give tyrosine and tryptophan to these patients. So clinical features, you can see white hair, white skin. Mental retardation is visible in few of the pictures. So aspartame, the artificial sweetener, is contraindicated because it has phenylalanine. Tetrahydrobiopterin, THB, tetrahydrobiopterin is given in non-classical cases of phenylketonuria, which is rare. Classical phenylketonuria is more common. Coming to maple syrup urine disease, the enzyme defective is branch chain alpha keto acid dehydrogenase or decarboxylase. The keto acids are accumulated, so patient will be having ketosis. Name of enzyme tells you ketosis. Maple syrup, so urine smells like sweet smell maple syrup. That is because of isoleucine, burnt sugar like odor because of isoleucine. Ketosis, vomiting, feeding problems. Mental retardation because of excess leucine here. Because in maple syrup urine disease, there is excess valine, leucine, and isoleucine. They are not broken down. Their catabolism is affected. Also, patient has abnormal muscle tone, and if not treated, then coma can occur. So coma or anything which affects brain, that is because of leucine. Yeah, valine, leucine, isoleucine are branch chain amino acids. They all are branch chain amino acids. Also, you can learn they all are essential. They all should be received in diet. Body cannot make it. So MSUD has high mortality rate. Death can occur. Treatment is restrict branch chain amino acids and vitamin B1 supplementation, because vitamin B1 is required for this enzyme branch chain keto acid dehydrogenase or decarboxylase. Then coming to Alkaptonuria or black bone disease. It is a defect in catabolism of phenylalanine and tyrosine. The enzyme affected is homogentisate oxidase or dioxygenase. Dioxygenase is the new name of this enzyme. So if both are given, prefer dioxygenase. Homogentisate chemically is dihydroxyphenylacetate. So recently question was asked and the word homogentisate was not given in the option, but dihydroxyphenylacetate was given. So be careful. So in these patients, treatment is a drug nitisinone, which inhibits the formation of homogentisic acid, because homogentisic acid is the culprit here. It gives black color to the urine by oxidation. That's why known as black bone disease. And this homogentisic acid, it gets accumulated in body, leading to the formation of alkapton bodies, which get accumulated in cartilages, so leading to discoloration of cartilage. Intervertebral disc calcification occurs, blue discoloration of sclera, spots on the eyes. Okay, and this condition is known as ochronosis, when bones and cartilages are affected because of alkapton bodies. Age of presentation is usually 40-year patient with back pain because of intervertebral disc calcification, right? Then is oculocutaneous albinism. The enzyme affected is tyrosinase. Tyrosinase is an oxidase. It requires copper. So this enzyme not working. So tyrosine cannot make melanin. So patient has hypopigmentation, lack of melanin in skin, hair and eyes. So there's increased risk of skin cancer, and ocular features like strabismus, nystagmus, blindness can occur. So it is very important to distinguish it from phenylketonuria because both have hypopigmentation, but no mental retardation in albinism and severe mental retardation in phenylketonuria. Then is homocysteinuria. Patient has chest wall deformities, marfanoid habitus, osteoporosis, thromboembolic disorders, ectopia lentis, short stature, genu-valgum, and mental retardation. Most of your amino acid disorders have mental retardation. Homocysteinuria can be because of enzyme defect, that is CBS, cystathionine beta synthase, or it can be because of vitamin deficiency, vitamin B6, B9 or B12 deficiency can lead to homocysteinuria. Then coming to galactosemia, we have two types of galactosemia. Minor, in which enzyme defective is galactokinase. Then patient has only oil drop cataract. It's a minor type. Then the most common galactosemia is classical type. Okay. Enzyme is GALT. Full form is galactose 1-phosphate uridyl transferase. The clinical feature is cataract, but in addition, liver and brain are also affected here. Because liver affected, so patient has jaundice, hepatomegaly, and mental retardation. Brain is affected, so mental retardation. Then is hereditary fructose intolerance, HFI. Here the enzyme is aldolase B. Aldolase B. Fructose 1-phosphate gets accumulated. It gets accumulated in liver, kidney. Patient has jaundice because liver affected. So jaundice, hepatomegaly, and hypoglycemia. Okay. If not treated, then renal failure can occur. Hypoglycemia is very important point here because there is no hypoglycemia for galactose disorder. And no cataract also. Yeah, Dr. Altaf, you're very right. No cataract in hereditary fructose intolerance. So questions will come to confuse you between galactosemia and fructosemia. So be very clear, crystal clear. If mental retardation, oil drop cataract or cataract written, it is galactosemia because there is no mental retardation and cataract in fructosemia. If hypoglycemia given, it is fructosemia because normal blood sugar for galactosemia patients. Okay, just these 2 pointers to help you diagnose the confusing questions on this topic. So I already know with my experience what confusing questions can be made because as a teacher sometimes I make questions. So it is my experience which you can take benefit of. But after my class, after my notes, do practice a lot of questions unless you get your confidence. And keep revising. Biochemistry is volatile, easy subject, but volatile subject. So please keep revising. You just need this input for Biochem that you should be doing it multiple times. So 3 cataracts are given on this next slide. Snowflake cataract, oil drop cataract, and sunflower cataract. Snowflake cataract because of sorbitol in the patients of diabetes. Oil drop cataract for galactosemia. Sunflower cataract in case of Wilson's disease, excess of copper. In Wilson's, excess of copper. Then a chart which will help you diagnose the questions. If a question is there where CNS is affected and hypopigmentation is given, it is phenylketonuria. If CNS affected with burnt sugar-like odor, it is MSUD. If a young person with stroke, hypertension, or cardiovascular attacks, also skeletal abnormalities, knock knees, pectus carinatum, elongated limbs, then it is homocysteinuria. If a question is a patient with organomegaly, easy bruising, bony pain, frequent fractures, and if some characteristic features also can be given, then think of Gaucher's disease. Coarse facial features generally means a lysosomal storage disease they're talking of. Coming to this next slide, again, a very, very important slide. It will help you help clear your confusion for questions on the enzyme deficiencies because all these are very common enzyme deficiencies. You know, G6PD is the first most common. And right here, first most common human enzyme deficiency. Second most common is pyruvate kinase. So let's do these first two. You know that pyruvate kinase is enzyme of glycolysis. G6PD is enzyme of HMP. Both have hemolysis. Okay, in both cases, hemolysis occurs. So, see, both are very common, both have hemolysis. So, obviously, a doctor will get confused that what is this, G6PD deficiency or pyruvate kinase? So, go for this detection of Heinz bodies. If you find Heinz bodies, it is G6PD deficient. Pyruvate kinase G6PD, go for Heinz bodies. Then PDH enzyme, the link reaction enzyme, pyruvate dehydrogenase. Here, patient has increased pyruvate lactate alanine. Okay, when this enzyme is not working, there's increased pyruvate, which will form alanine, which will form lactate. So, patient will be having lactic acidosis, but no lactic acidosis in pyruvate kinase deficiency or G6PD deficiency. In pyruvate kinase deficiency, in fact, there will be decreased pyruvate lactate and alanine. Coming to the next very important topic of lipoproteins. Lipoproteins, very, very important and very easy topic. Again, just 2-3 slides I'll give you for this topic and you're good to solve all your questions. If you understand my slides in this short format, then you're good to go. If you need more details, you can watch my detailed videos, right? Okay, Dr. Saurav, now perfect? Great. So the lipoproteins we always do in this sequence. First we do chylomicrons, then it's remnant, chylomicron remnant, then VLDL, then it's remnant IDL, then LDL, HDL. In this sequence, density is increasing. So least density for chylomicron, highest density for HDL. Okay. Density is increasing. So that's why the name high density lipoprotein, HDL. Now chylomicron is synthesized in intestine. It has only triglyceride and the protein is ApoB48. Okay. Always for remnant, you add cholesterol here, you add ApoE here. So Tg plus cholesterol, ApoB48 plus ApoE, right? Then VLDL has endogenous triglyceride. Chylomicron has exogenous triglyceride. VLDL has endogenous triglyceride. Protein is ApoB100. It is synthesized in liver. VLDL synthesized in liver. I told you for remnant, add cholesterol, add ApoE. So this is Tg plus cholesterol, ApoB100 plus ApoE. LDL has only cholesterol and same proteins as IDL. Next, HDL has cholesterol ester, very important point. If you add one fatty acid in cholesterol, it becomes cholesterol ester. Then protein is ACE, ACE, ApoA, ApoC, ApoE, right? LDL takes cholesterol from liver to peripheral tissue. HDL will do reverse of it from peripheral tissue to liver. So it will do reverse cholesterol transport. Then hyperlipoproteinemias, Fredrickson classification. Type 1 hyperlipoproteinemia. The defect. What is the defect? Defect is in lipoprotein lipase enzyme, lipoprotein lipase, or the activator of this enzyme, that is ApoC2. Okay, ApoC2. So which lipoprotein will increase? Chylomicron and VLDL both will increase, but increase in chylomicron is more. Lipoprotein which is increased is chylomicron and VLDL. The lipid which is increased is triglyceride. Cholesterol is normal. So it is known as familial hyperchylomicronemia. Okay, familial hyperchylomicronemia. Then type 2A, the defect is in LDL receptor or ApoB100. LDL receptor or ApoB100. The lipoprotein increased is clear, LDL. The lipid which is increased is triglyceride normal and cholesterol is increased. Because cholesterol increased, so it is known as familial hypercholesterolemia. Then type 2B, the defect is unknown. Defect is unknown, but lipoprotein increased is VLDL and LDL both. And lipid increased are both TG and cholesterol. This is known as familial combined hyperlipoproteinemia. Yeah, these 2-3 slides in lipoprotein topic are good to go for solving any question. I told you my God gift of making concentrated, light, and conceptual short notes. So you please take benefit of this. Type 3, the defect is in ApoE. So both remnants will increase, chylomicron remnant, VLDL remnant. Triglyceride is increased, cholesterol is increased. This is known as dis-beta lipoproteinemia. Okay, dis-beta lipoproteinemia. So this chart very important. If you know this chart, it is very easy to solve the questions. Then frequently asked is Tangier disease with orange, enlarged, yellow tonsils. Tangier's disease, there is decrease HDL in these patients. Decrease HDL, okay, also called familial alpha lipoprotein deficiency because HDL is known as alpha lipoprotein. So in Tangier's disease, ABCA1 transmembrane protein is defective. There is cholesterol accumulation because HDL is not formed, so it will not take cholesterol from the peripheral tissue. So cholesterol will be accumulated in many of the tissues, like in tonsils, that's why enlarged orange tonsils. And oranges are tangy. Oranges are tangy. So orange tonsils, Tangier's disease, which is a characteristic feature. Also cholesterol accumulation in liver, spleen, lymph nodes. So patient has hepatosplenomegaly, peripheral neuropathy, mononeuritis multiplex. These are the clinical features, right? Then one chart we will do. If in such questions they write, in the question of lipoproteins, they write tendon xanthoma, what that means is cholesterol is increased. Eruptive xanthoma means triglyceride is increased. Palmar and tuberoeruptive xanthoma means remnants are increased. Milky plasma means chylomicrons increased. Acute pancreatitis or acute pain abdomen means triglyceride is increased. So we are done with lipoprotein topic. Just have a look. We just did these 2-3 slides. First this slide, which lipoprotein has which lipid and which protein, right? This you should know. And then only these 4 hyperlipoproteinemias, type 1, 2A, 2B and type 3. This much is enough. Only this thing is asked. Okay. I have full confidence on what I'm telling you. There's no need to do any extra thing because you have to complete 19 subjects, right? So yeah. And then this slide of Tangier's disease frequently asked. Okay. And then this one table, which xanthoma means what thing is increased. Okay. Let's start from urea cycle. Okay. I hope session is good going. You're able to understand, although it is rapid revision session, but all these are important topics and the concepts, whatever concepts I can teach you in this short session, I am teaching. Okay. So urea cycle also known as Krebs-Hanslet cycle. Okay. Krebs cycle is TCA cycle. Urea is Krebs-Hanslet. And this occurs in both mitochondria and cytoplasm. Both mitochondria and cytoplasm. It starts from mitochondria. So carbon dioxide and ammonia joins to make carbamoyl phosphate. The first step of urea cycle occurring in mitochondria by this rate limiting enzyme CPS1 carbamoyl phosphate synthetase 1. Synthetase means ATP is used. In fact, 2 ATP used here. If synthase, the smaller name, then ATP is not used. Okay. Second step is by enzyme OTC, ornithine transcarbamylase. This OTC is absent in brain. Okay. So urea cycle will not occur in brain. Here ornithine added and we get citrulline. Citrulline comes out of mitochondria, goes into the third step of urea cycle where aspartate is joined and we get a big compound arginosuccinate. Here ATP used. So synthetase enzyme, AS synthetase, in short ASS. ATP forms AMP. This is equivalent to 2 ATP used at this step. Then fourth step, AS lyase. Now you break down. Lyase means break down this big compound. And fumarate is released, which goes to TCA cycle. And on the other hand, we get arginine, which will continue the urea cycle. So fourth enzyme, AS lyase, and last and fifth enzyme, arginase. Arginine broken down into urea, which is excreted via urine. On the other hand, ornithine continues the cycle. This last enzyme, arginase, is absent in kidneys, but other four enzymes are working in kidneys. So if I ask you, what is the end product of urea cycle in kidneys? What is the end product of urea cycle in kidneys? Yes, arginine, because last step is not occurring. Or we can say we obtain arginine, which is a semi-essential amino acid. We obtain it in kidneys. So how many ATPs are used to make one urea? 4 ATPs used to make one urea. 2 at the first step and 2 at the third step. Okay. Then sources of carbon and nitrogen in urea. The carbon is from bicarbonate or carbon dioxide. The other two nitrogens, one is from ammonia, other is from aspartate. Aspartate, you remember it was getting added at the third step. Okay. So urea has one carbon, two nitrogens. The one carbon is from carbon dioxide or bicarbonate. The two nitrogens from ammonia and aspartate. Be careful, this also starts from A, this also starts from A. So when they give you MCQs, they will confuse you. They'll write asparagine, alanine, something like that. So be careful, it is ammonia and aspartate, not asparagine, not arginine, not alanine. Okay, be careful. Then is hyperammonemia, the concept of hyperammonemia. Clinical features of hyperammonemia are very important. So clinical features are there is increased glutamine, increased alanine, decreased BUN, decreased blood urea nitrogen. Patient has cerebral edema, confusion, headache, vomiting, seizures or fine tremors, and decreased energy because TCA cycle is affected. Alpha ketoglutarate of TCA cycle is depleted. Frequently asked, alpha ketoglutarate, which TCA intermediate is depleted in hyperammonemia? That is alpha ketoglutarate. Okay. So urea cycle defects. So I told you these are 5 enzymes of urea cycle. First is rate limiting CPS1, then it was OTC, then third ASS, then ASL, lyase, fifth is arginase. The defect in first one is known as hyperammonemia type 1. The defect in OTC is hyperammonemia type 2. Patient has increased orotic acid, OMP and UMP. So hyperammonemia, that is increased ammonia, will occur in all the urea cycle defects. Here also increased ammonia will occur in all of them. If a question says increase ammonia and orotic acid or OMP increased, it is OTC defect, which is the most common urea cycle defect. Then if AS synthetase is defective, it is citrullinemia. AS lyase is affected, it is arginosuccinic aciduria. If arginine is the last enzyme defective, then hyperargininemia. Most severe are hyperammonemia type 1 and type 2 because after type 2, ammonia is organic. Before that, ammonia is inorganic. And inorganic ammonia is more dangerous. So most severe out of all is type 1 and type 2. Treatment of urea cycle disorder. First line treatment is arginine. But arginine is contraindicated in this last one, arginase defective. Then ammonia scavenging agents like phenyl butyrate and sodium benzoate are used. Okay. Then coming to, if a question says increase orotic acid in blood and urine, then it can be two diseases, but you need to differentially diagnose. It is OTC deficiency from urea cycle defect, or it is from pyrimidines or orotic aciduria. See how to distinguish. If there is increase OMP and UMP, it is OTC deficiency. If decrease OMP and UMP, it is pyrimidines. It is orotic aciduria. If megaloblastic anemia, it is orotic aciduria. If hyperammonemia present, then it is urea cycle defect, OTC deficiency. So again, this slide you will not find in any book or anywhere else. I have specially worked on this whole PPT for you guys for this session, right? So this is very important to distinguish between these two. Otherwise, quickly when you will see increased orotic acid in blood and urine, you might go towards OTC deficiency. But you need to be very careful in reading the question once again, and you should be having this in mind that it can be OTC deficiency or orotic aciduria. Then next diseases which we are going to see on this page is xeroderma pigmentosa and HNPCC. They occur because of the repair defect. So xeroderma pigmentosa occur because of the defect in nucleotide excision repair. The damage is thymine dimers. The cause is UV radiation damage. So I'm writing Q where question is asked. HNPCC, hereditary non-polyposis colorectal cancer, occur because of mismatch repair defect, due to defect in mismatch repair. Okay. Next, very frequently asked and a very basic point to know for a doctor, that if a patient with hypoglycemic attack and the patient is alcoholic, it is quite common if you work in emergencies. First, you should give B1 or first you should give glucose. You should be very clear. It is a blunder if you give glucose first, although the patient has hypoglycemia, but don't give glucose immediately. First, you give an injection of vitamin B1. Then we slowly give glucose, because vitamin B1 is required for glucose metabolism. And these patients, alcoholic patients, I told you they have B1 deficiency for sure. Okay. Then raw eggs, a question associated with raw eggs. You all might be knowing the question. It is B7 or biotin deficiency, which occurs after consumption of raw eggs, because raw eggs have a protein, avidin, which inhibits the absorption of biotin, right? Okay. So biotin, if affected, B7 is required for carboxylase enzymes. One very important pathway which require carboxylase, pyruvate carboxylase, is gluconeogenesis. If gluconeogenesis is affected, hypoglycemia will occur. If the patient is not eating food, doing gym, and the gym trainer has prescribed raw eggs, and the patient is eating less, so he will be having a lot of episodes of fasting. During fasting, this carboxylase enzyme is not working, so gluconeogenesis cannot happen. So patient will be having a hypoglycemic attack, right? So alcoholic patient with hypoglycemic attack, it is B1 deficiency. If a person consuming raw eggs, going to gym, and that person having hypoglycemic attack, that is because of biotin deficiency. Carboxylase affected. The pathway which is affected is gluconeogenesis. Each and every word on this slide is very important. Please note all these points. Fasting hypoglycemia, gluconeogenesis affected. Then vitamin B2, that is riboflavin. So if B2 deficiency, it is riboflavinosis. Patient has glossitis, also called magenta tongue or geographical tongue. Also has chelosis, that is inflammation at the corners of mouth. Also has pink eyes, also called corneal vascularization, like because of corneal vascularization. Very important marker enzymes. Marker enzyme for B1 deficiency is transketolase activity. Be careful, not the quantity of enzyme. It's the activity. For B2, it is glutathione reductase. Be careful, it is not glutathione peroxidase. It is glutathione reductase. Okay. For B6, it is transaminase. Transaminase. B6. For B1, transketolase. For B2, glutathione reductase. For B6, transaminase. Then look here, homocysteine is accumulated whether it is B6 deficiency or B9 deficiency or B12 deficiency. So how will you distinguish it is B6, B9 or B12? If they have written xanthuranic acid, then it is very clear it is B6 deficiency. If figlo excreted in urine, that is form-aminoglutamate, it is B9. In B12, L-methylmalonic acid is accumulated. Also, you can note that L-methylmalonic acid is responsible for the peripheral neuropathy of B12 deficiency. Okay? Very important, homocysteine increased in all three vitamin deficiency, B6, B9, B12. Then for vitamin A, I have written vitamin A deficiency signs also and toxicity signs also on same slide so that you don't get confused and you're able to remember. So left side, vitamin A deficiency signs, mostly affecting eyes, xerophthalmia, keratomalacia, the dryness in the eyes, basically, in short, okay, dryness in the eyes. So normally vitamin A suppresses keratinization, but now keratin deposits will occur in skin, in eyes. So mostly because of excess keratin. So see, follicular hyperkeratosis, excess keratin in conjunctiva, leading to foamy appearance, known as characteristic Bitot spot of vitamin A deficiency. Then other features, immunosuppression, skin ulceration, corneal ulceration and scarring, atrophy of urinary tract, respiratory tract, leading to recurrent infections in vitamin A deficiency. So mainly eyes affected, dryness of eyes, immunosuppression, skin ulceration, follicular hyperkeratosis, Bitot spots, and recurrent infections. On the other hand, vitamin A toxicity. Vitamin A gets accumulated in liver. Excess of vitamin A in liver will damage liver, will enlarge liver, will affect the metabolism of liver. So hepatomegaly, liver damage, hyperlipidemia, and also raised intracranial tension, which gives so much headache and so much intracranial tension raised that it resembles a brain tumor known as pseudotumor cerebri. Patient has blurred vision, alopecia, and pruritic skin also. So skin here affected. So note here, there's in toxicity also, there's little effect on the eyes, leading to blurred vision. In deficiency of vitamin A, dryness in the eyes, xerophthalmia and keratomalacia. In vitamin A toxicity, just one sign from the eyes is blurred vision. Okay. Then Cation disease was named because of a province in China, that is Cation, because selenium deficiency was found in this area and the patients were affected, especially children and women of childbearing age. So heart affected in these patients, cardiomyopathy, heart, then muscles, skeletal muscles, heart muscles. So muscle weakness, muscular dystrophy, inability to gain weight, hypothyroidism, hypertension, eczema, arthritis. Also, it is related to cancer. Selenium poor soil associated with high incidence of cancer. Right? So cardiac muscle and skeletal muscle is mainly affected. Thyroid affected and arthritis, joints, eczema. Right? Just read all these features once. If question comes, you'll be able to remember. Then coming to copper diseases related to copper metabolism. One is Menkes, other is Wilson. M for Menkes, W for Wilson. So M alphabet comes before W, na? So M is copper deficiency, M Menkes copper deficiency, ATP7A protein defective. But in Wilson, copper excess, ATP7B protein is defective. Okay. So let's read about Menkes first. Copper deficiency, ATP7A protein defective, which absorbs copper from intestine. It is X-linked recessive. There's decreased ceruloplasmin. Ceruloplasmin is the copper transport protein. Ceruloplasmin, copper transport protein, because copper is not there, so it is decreased. Patient has kinky hair, you can see the picture. Hypopigmentation also. Mental retardation, grey kinky hair, anemia, neutropenia. Okay. Hypopigmentation because tyrosinase enzyme which makes melanin, that also requires copper. I told you. Coming to Wilson's disease, copper excess affecting mainly eyes and liver, known as hepatolenticular degeneration. ATP7B protein, it has two work. One is it will throw copper in bile. The only route of copper excretion from body is bile. So copper is not going out of the body, so copper gets excess in the body. It will get increased in liver first damaged liver. Then there's so much of excess, it will start going to kidneys, bone marrow, brain, RBCs, damaging RBCs, leading to hemolytic anemia. So anemia also occurs in Menkes disease also, and in Wilson also there's anemia, but it is hemolytic anemia. One more work of ATP7B protein is incorporation of copper into ceruloplasmin. Okay. So here also there's decreased ceruloplasmin. So can I say ceruloplasmin decrease in both Menkes and Wilson? Okay, and Wilson is autosomal recessive, like your all biochemistry disease, most of your biochemistry diseases. In Wilson, there is increased urinary copper but low serum copper. Okay, increased urinary copper but low serum copper. Then fluorine, which is a double-edged sword, both deficiency and excess are harmful. Deficiency, less than 0.5 parts per million in drinking water, will lead to dental caries, which is acidic destruction of enamel and dentine. Excess of fluorine, more than 5 parts per million, will lead to dental fluorosis, in which patient has decreased mineralization in enamel. More than 20 parts per million, skeletal fluorosis, in which patient has genu, valgum, knock knees, and osteoporosis and osteosclerosis. Bones are so brittle and they are bent, abnormal hardening of bones. Then next slide, very important these days, it's frequently asked about the colors of the vacutainers. So red color, no anticoagulant is present in it. It is for the normal serological examination in biochemistry. Gray color, having sodium fluoride for glucose estimation. Sodium fluoride inhibits which enzyme? It inhibits which enzyme? Enolase of glycolysis. That is your biochemistry question. Lavender or purple color having EDTA for your pathological examination like hemogram and ESR. Blue color having sodium citrate for coagulation studies. Green color having heparin for bone marrow studies. Yellow having citrate for blood culture. Pink having EDTA for blood banks. Blood bank, blood grouping and ABO grouping, right? Then recently order of draw was asked. What is the order of draw? The mnemonic here is Brigel Gray. BRYGL, and the last one is gray because there are two G. First G is green and the latter G is gray. So the mnemonic I have made is Brigel Gray. So first culture tube, then B for blue, R for red, Y for yellow, then G for green, L for lavender, and then last gray. This is the order of draw. Sometimes it is asked. So you should know each color having which anticoagulant or which thing, what is the use of it, and also the order of draw. Just this one slide, you are done with this topic. No need to search for this topic anywhere else. You're done with it. Whatever questions have been asked till date, and this is enough for you. Okay, then a slide on GAGs about their location and their function. This is frequently asked. Hyaluronic acid is the longest GAG present in synovial fluid and vitreous humor. It has role in wound healing and cell migration, which is required during morphogenesis and tumor cell migration. Then chondroitin sulfate, as the name says, chondra, so cartilage, bone, tendon, ligament, also cornea. Then keratin sulfate, present in cornea. The main one in cornea is keratin sulfate. So question was asked, which is responsible for transparency of cornea? It is keratin sulfate. Dermatin sulfate, present in skin, blood vessels and valves. Heparin, the anticoagulant released from mast cells and liver. Heparin sulfate, present on cell surfaces, having a role in cell-cell attachment, also in the basement membrane of glomerulus. Then products of amino acids are frequently asked. Tryptophan makes niacin. I told you already. Melatonin. Melanin is from tyrosine. Melatonin from tryptophan. Also serotonin. Okay. Histidine gives histamine, carnosine, anserine. Glycine. Although it's the smallest, simplest amino acid, but there are a lot of products obtained from glycine. Example, creatine, glutathione, heme and porphyrins, glyoxylate, choline, betaine, sarcosine, another amino acid. Serine is also obtained from glycine. Then glutathione is a tripeptide made up of 3 amino acids. Gluta stands for glutamate. Thia stands for cysteine. One means the simplest, smallest amino acid, that is glycine. Okay, this way you can learn. The name tells you glutathione or glutathione. Gluta means glutamate. Thia means cysteine because it has sulfhydryl group. So we represent glutathione as GSH with the sulfhydryl group, which is very important in it. And glycine. One stands for the simplest, smallest amino acid, glycine. Next is creatine. Creatine is made from 3 amino acids. That is arginine, methionine, which is having sulfur but not sulfhydryl group, and glycine is common to both of them, right? Next is serine. Serine can make glycine, serinocysteine, the 21st amino acid. It is also used to make cysteine, which is non-essential amino acid. Then phosphatidylserine and sphingosine. Sphingosine is made up of serine and palmitoyl-CoA. Then arginine, very important, frequently asked. Like question on this Kazel's necklace is frequently asked. Similarly, product of arginine, frequently asked. 4 or 5 times it has been asked in your exam. So arginine makes nitric oxide, the vasodilator, creatine, urea, ornithine. And I told you arginine is the first line of treatment in urea cycle disorders. Then some one-liners from your FMGE exam, June 19. Enolase inhibited by sodium fluoride, so used in the gray vacutainer. I told you. Maple syrup urine disease, I told you. Alpha keto acid dehydrogenase or decarboxylase. Collagen is rich in which amino acid? Glycine. Every third amino acid is glycine. Nitric oxide derived from arginine. We have done most of your last year exam questions and topics and concepts. So now we can just take it paper wise. De novo synthesis of fatty acid require which coenzyme? NADPH. NADPH is required in the anabolic pathways, like synthesis pathways. So synthesis of fatty acid require NADPH. Coenzyme for dehydrogenases are NAD, FAD, and ADP. After strenuous exercise, alkaline skeletal muscle pH. Alkaline means it is not acidic. Otherwise, lactic acidosis will occur after exercise. But here in this patient, lactic acidosis is not occurring. I already told you it is the characteristic feature of type 5 glycogen storage disease, McArdle's disease. Most potent lipid phase antioxidant is vitamin E. Vitamin E works in association with glutathione and vitamin C. They all work together to have an antioxidant effect in the cells. Wernicke encephalopathy caused by deficiency of vitamin B1. So all these one-liners are taken from the questions which were asked. Most specific marker of pheochromocytoma, VMA, vanillyl mandelic acid. Which cells release histamine? Mast cells. Then let's do lipotropic factors. Lipotropic factors, they prevent fatty liver. They are very good for the body. They prevent fatty liver. They are all the PUFAs, example linoleic, linolenic acid, polyunsaturated fatty acids. Then 2 vitamins, B9 and B12. Then 3 amino acids. So 2 vitamins, 3 amino acids. These 3 amino acids are glycine, serine, methionine. Then choline, betaine, inositol. Please cram all the lipotropic factors. Then a question was frequently asked, pigmentation at knuckles and oral mucosa is seen in. So it's quite a feature of vitamin B12 deficiency. Dark pigmentation at the knuckles and oral mucosa. The lipoprotein which is cardioprotective, very easy. You all know HDL is cardioprotective. Gluconeogenesis is inhibited by, it is insulin. You can easily learn this from my 4 SMILE formulas. All these things about insulin, glucagon, phosphorylation, dephosphorylation, and pathways can be learned from the formulas. Then which structure of protein is not denatured after heating up to 100 degrees Celsius? This is primary structure is not denatured. Secondary, tertiary, quaternary structures are destroyed. Glucose transporter present in skeletal muscle is GLUT4. So GLUT4 present in cardiac muscle, skeletal muscle, peripheral tissue basically, right? Synovial fluid contains hyaluronic acid, I already told you. Melanin from tyrosine and melatonin from tryptophan. Bases which are present in human DNA are A, T, C, and G. Adenine, thymine, cytosine, guanine. And in RNA we have, in RNA, instead of thymine, there is uracil. A, U, C, and G. Just this one difference. Uracil instead of thymine in RNA. Type 4 complex of ETC is inhibited by cyanide. Other inhibitors of type 4 are cyanide, carbon monoxide, hydrogen sulfide, right? Zinc is a cofactor for carbonic anhydrase. Then allopurinol inhibits enzyme xanthine oxidase. It is a suicide inhibitor here. Okay. Then energy you will yield from 1 gram of protein is 4 kilocalories. From carbohydrate also 4 kilocalories. From fat it is 9 kilocalories per gram. More than double, that is 9 kilocalories per gram. Okay, ammonia formed in brain is transported in the form of glutamine. So if brain asked or body asked, it is glutamine. If same question asked for muscles, it is alanine. Cation disease due to deficiency of selenium. Most sensitive screening for vitamin A deficiency is serum retinol levels. Okay, because if you are directly checking serum retinol levels, then it's very sensitive. Enzyme activity level tested in thiamine deficiency. I already told you marker for B1 deficiency is transketolase activity. Okay, transketolase activity, not the quantity of enzyme. Most abundant amino acid in collagen. This is frequently asked, repeated question. It is glycine. Specific test for uric acid, very specific for uric acid increase is the synovial uric acid, because in the synovial joints it will get accumulated mainly. So it's very specific. Then next is enzyme deficient in Tay-Sachs. It is hexosaminidase A. What was in Sandoff disease? Both hexosaminidase A and B. Vitamin deficiency in patient with macrocytic anemia and normal methylmalonyl-CoA, but increase homocysteine. See, increase homocysteine, I told you, for B6, B9, B12, all will be having. Macrocytic anemia means it is either B9 or B12. If methylmalonyl-CoA is normal, it cannot be B12. So, by exclusion, it is B9, right? Very easy to do this question. I told you that chart of homocysteine. Next, LDH isoenzyme elevated in patient with sudden chest pain is the type 1 LDH enzyme, which is present in heart. Inheritance when mother's side uncle and her son has disease. So mother is not having the disease. Mother's uncle had disease. Now her son is having the disease. So there is no male to male transmission. Female is the carrier. This thing occurs in case of X-linked diseases. And this is X-linked recessive. Right? No male to male transmission is in X-linked diseases. When mother is the carrier and mostly males are affected, it is X-linked recessive. Alcoholic patient with neurological symptoms, again, this is frequently asked. Deficiency of B1 and alcohol, highly associated. Then FMGE August 2020 exam one-liners. Cofactor for mitochondrial SOD is manganese. Otherwise, cytoplasmic SOD requires copper. Cytoplasmic superoxide dismutase requires copper. Then nitric oxide, tramarginine, repeated question. I'm just writing R for the repeated question. Protein which are involved in protein folding, that is chaperones. It is chaperones actually, but we pronounce it as chaperones because they help in folding and giving shape to the protein, because the shape comes from the folding of the protein. So patient has swelling in MCP joints, there's increased uric acid, doctor prescribes allopurinol. So this medicine is against which enzyme? Xanthine oxidase. There is also a repeated question, just the format of the question is changed. These days they are giving big questions with the clinical case scenario, so that you are able to handle it, you're able to prime it in the form of a patient, right? Not a very theoretical point of view. So in fatty liver, which is not given, I told you lipotropic factors prevent fatty liver. So if any lipotropic factor is given, fatty liver will not occur, but ethanol or alcohol will cause fatty liver. Other three options in this question were lipotropic factors. Then coming to your June 21 exam, ATP7A protein is deficient in Menkes disease. Iron chelator used in the treatment of iron overload is desferrioxamine. Hormones that regulate serum calcium levels, vitamin D, PTH. Both vitamin D and PTH increase blood calcium. Calcitonin will decrease blood calcium levels. It will increase calcium in bones. Glutathione peroxidase contain which metal? Selenium. Or we can say selenocysteine, the 21st amino acid. Very important topic, selenocysteine. A patient with intellectual disability, hyperuricemia, very characteristic self-mutilation. Tell me the answer. Self-mutilation behavior. You can see biting of the fingernails, the lips, eyes are not shown. Syndrome, HDPRT deficiency. Leishman enzyme affected is HGPRT, hypoxanthine guanine phosphoribosyl transferase. Fat is stored in which form in the tissue? In the body. Triglyceride is the storage form of fat. What mechanism is defective in xeroderma pigmentosa? Nucleotide excision repair. Okay, we have done that. Next, enzyme deficient in von Gog's disease is Glucose 6-phosphatase. Alcohol, again, repeated question, alcohol and B1. See, so many times you're asking this. Patient is having fatigue and weakness, low hemoglobin and iron levels, delayed wound healing. So, low hemoglobin, low iron. Vitamin C helps in absorption of iron, right? Vitamin C helps in wound healing. So, answer is vitamin C. You can also note that delayed wound healing occurs in many things deficiency. Main is zinc. Zinc is highly associated with wound healing. Then copper, iron, vitamin C, vitamin B1, B2, B5, fat-soluble vitamins, vitamin A, D, E, K. Most sensitive test for monitoring treatment response in chronic myeloid leukemia. Answer is RT-PCR. So this is RT-PCR stands for real-time PCR. Okay. It is most sensitive and accurate test for measuring treatment response in CML. It doesn't require a painful bone marrow aspirate. Peripheral blood sample is only used. So it's very easy to obtain the peripheral blood sample. It measures the number of cells that have this BCR-ABL gene. It is so sensitive that it can find one leukemia cell out of 1 million normal cells. Okay. So real-time PCR is very sensitive and accurate. Okay, next is your exam, June 2022. ETC complex 4 is inhibited by cyanide. Again, it repeat question, repeat topic. Bitoid spots seen in deficiency of vitamin A, very specific. The foamy keratin deposition in the conjunctiva. 5-hydroxyindoleacetic acid increased in carcinoid syndrome. Dark color on diaper, which enzyme deficiency? So dark color on diaper and many other things were, many other non-specific things were written in the question. A clinical case was given. In short, the main point was dark color on diaper. So which enzyme deficient? It is Alkaptonuria. So homogentisate dioxygenase. Vitamin that is most commonly associated with tingling sensation is vitamin B12. Typical pin and needle sensation in hand, feet, face. Vitamin B6 deficiency can also cause tingling sensation, but more commonly associated is B12. Then January 23 paper, melanin synthesized from tyrosine, glycolysis occurs in which compartment of the cell? Cytoplasm. Pathway which occur both in mitochondria and cytoplasm, mnemonic, hug, H, U, G. H for heme synthesis, U for urea cycle, G for gluconeogenesis. Vasodilator nitric oxide synthesized from arginine. Repeat question. Xerophthalmia conjunctival xerosis occurs due to deficiency of vitamin A. Very easy. Can you see all these are so easy questions. I've just taken 2 hours of teaching here and your most of the one-liners from these last 11 papers of FMG is done. Okay, omega-3 fatty acids are useful for coronary artery disease prevention because omega-3 are cardioprotective. This is also a repeat question. Although ApoB48 and B100 derive from same gene but finally translated into separate proteins, we have done this, RNA editing. Absolute contraindication for breastfeeding is galactosemia, not any infection. Even if mother has HIV or hepatitis B, then also breastfeeding is not contraindicated. But in galactosemia, it is contraindicated because it can lead to mental retardation. Because if you remember, classical galactosemia leads to mental retardation. Okay, very important point. Accumulation of sorbitol leads to diabetic cataract. Sickle cell anemia, glutamate substituted by valine at 6th position. Patient has liver damage, sunflower cataract. What is the answer? What is the diagnosis? See, whenever a big clinical question is given, you have to pick your pointers. See, liver damage, sunflower cataract. These two words are enough for your diagnosis. It is Wilson disease, na? Patient has neurological manifestations. So which factor is responsible for the disease? Copper. Mode of action of dicumarol and warfarin is inhibiting the enzyme epoxide reductase in vitamin K cycle. Please do vitamin K cycle. It is very important. It's very easy also. Which amino acids can prevent cardiac problem? If such question is asked, your best answer will be glycine. Okay, the smallest, simplest amino acid is cardioprotective. Then if glycine is not given, then mark taurine. If taurine is not given, then mark leucine. Okay, the anterior incisors of a child with white patches turned brown following over supplementation of what thing? Fluorine. Usually it is in the drinking water, excess or deficiency of fluorine. Then following are the reasons for thiamine deficiency except. So B1 deficiency, this question was recently asked. Alcohol, diuretic, bariatric surgery, chronic renal failure, all are reasons of B1 deficiency. But veganism will lead to B12 deficiency, not B1 deficiency. Veganism, these people do not take any milk and milk product also. Okay, next question, read the question. COVID patient discharged from hospital was recovering at home. In order to join back his duties, he himself started taking excess multivitamin. So, you need to pick your pointers from this lengthy question. Okay, one pointer we have picked till now is excessive multivitamin. And he developed symptoms of nerve sensation, tingling sensation. Which of the following is most likely cause of associated symptoms seen in this patient? So, one of the option is B6, okay? So, answer here is pyridoxine toxicity. We did this earlier also. Sensory neuropathy occurs here. Numbness, tingling and pain in extremities. Okay. This is called mega vitamin B6 syndrome. Also, patient has seizures, photosensitivity, GI symptoms, impaired glucose tolerance. So, in B6 deficiency also, neuropathy occurs. In B6 excess also, this nerves are affected. Vitamin B6 or pyridoxine is unique in that either a deficiency or an excess can cause a neuropathy. Next, which is not a micronutrient. If less than 100 milligram per day, then it is micro. If more than 100, it is macro. You can use your common sense here. Calcium, phosphorus present in bones, obviously they are required in more amount. Sodium, potassium chloride present in blood and cells. And also magnesium and sulfur, they are macro. Okay. So obviously calcium is a macro, not a micro. So just learn the macro, only these 7. Calcium, phosphorus, sodium, potassium chloride, magnesium and sulfur. Rest all are micro. Okay. Easy to learn. Always do smart study. Don't waste your time in unnecessary cramming. Just do the macro and all others are micro. Glycemic index. It is a measure of increase in blood glucose after we give a test dose of carbohydrates, especially glucose. So a food with high GI will suddenly raise blood glucose and it is not good. Highest glycemic index of glucose and galactose. That is 1. Minimum dietary fiber, that is 0. Low glycemic index for fructose, sucrose, starch, sugar alcohols. So, example, low GI, fructose, beans, grains, pulses, all vegetables, most fruits. Medium, so banana, we all know it's heavy, so it has medium GI. Table sugar or sucrose. High glycemic index, glucose, galactose, maltose, high fructose corn syrup, all the sweets, all the bakery items, all the white things, processed, white rice, white bread, potato. So some common sense and just reading the topic once, you will be able to solve whatever question will come. So answer yes, you are right. Answer is glucose. Which of the following enzyme simultaneously incorporate oxygen and produces water? It is complex 4 of ETC, that is cytochrome C oxidase. It incorporates oxygen and producing water. You can use the image to understand this point. Then there are 3 confusing drugs: dicumarol, dimercaprol, disulfiram. So dicumarol is the vitamin K antagonist used as anticoagulant. Dimercaprol, British antirecite, it inhibits complex 3 of ETC. Disulfiram, used in alcohol and abuse. So disulfiram inhibits enzyme aldehyde dehydrogenase. Aldehyde dehydrogenase. Okay, coming to next slide. Tell me the answer. Patient presented with a collagen vascular disorder. Which of the following deficit is most likely to be associated with defective collagen formation? For collagen, we require vitamin C, that is ascorbic acid, copper, iron, both A and B are required. Because proline and lysine are hydroxylated to hydroxyproline hydroxylysine. For the hydroxylation, prolyl hydroxylase, lysyl hydroxylase enzymes require vitamin C and iron. Then for making the cross-link formation, lysyl oxidase is required, which require copper. So copper and iron are the minerals required. Vitamin is vitamin C, which is required. So FMGE July 23 exam. Aspartate forms which are the following intermediate of TCA cycle. So aspartate can form oxaloacetate. You can also note that glutamate or glutamine can form alpha ketoglutarate of TCA cycle. Diarrhea by cholera toxin involves which receptor? Just cram this, GM1 ganglioside receptor. A neonate on breastfeeding develops jaundice. Repeated question, galactosemia, urine Benedict's test positive, enzyme deficiencies, GALT. 5-fluorouracil causes thymineless cell death because of inhibiting the enzyme thymidylate synthase. This enzyme converts pyrimidine U to T. Okay, U-uracil, T-thymine. Then transport of glucose on the contraluminal or the basolateral side of intestine is done by GLUT. You can see this diagram. This is the luminal side of intestine. Here there is sodium glucose import or the active transport. Then at this side, the contraluminal or the basolateral side of the membrane, there is this GLUT, glucose transporter. Increase homocysteine in which enzyme deficiency? I told you, cystathionine beta synthase. Increase homocysteine in which vitamin deficiency? I told you, B6, B9 or B12. Then FMG Jan 24 paper. In arterial blood gas analysis, the measured values are pH, partial pressure of carbon dioxide, partial pressure of oxygen. However, bicarbonate and base excess deficit are then calculated. So you need to learn the measured values are pH and the partial pressure, but the calculated values are bicarbonate, base excess and oxygen saturation. Enzyme defect in type 2 tyrosinemia. Usually tyrosinemias are very rare, but this question was once asked. So type 2 tyrosinemia, there are two T's in the name. Tyrosine transaminase. Easy to learn, type 2, two T's in the name, tyrosine transaminase. Clinical feature of vitamin C deficiency or scurvy are fatigue, joint pain, bleeding and swelling of gums, petechiae. Very easy, you all know scurvy. Glossitis cheilosis occurs in the deficiency of vitamin B2, 3 and 6. Clinical features of niacin deficiency, the D's. We have already done that. Amino acid, which is precursor of niacin, is tryptophan. Again, a repeat question. The receptor, which plays a crucial role in glucose uptake by skeletal muscle. Again, a repeat question. It is GLUT4. Rate-limiting enzyme of cholesterol synthesis, HMG-CoA reductase, which is inhibited by statins. Rate-limiting for ketone body synthesis is HMG-CoA synthase. Be careful. For cholesterol synthesis, it is HMG-CoA reductase. For ketone body synthesis, it is HMG-CoA synthase. Rate-limiting for HMP pathway is G6PD. All TCA enzymes are present in mitochondrial matrix except succinate dehydrogenase. Okay, so RNA sequence is given. They're asking the sequence of template strand. For solving these questions, understand how I'm going to do it. Always do the same way. So RNA sequence is given CAAGGU. Now obviously this is left is 5 dash, right is 3 dash. Now whenever they're asking a template strand and you have RNA, first make the non-template strand, because from RNA to non-template strand, direction is same, codons are same, you just need to change U with T. So direction same, 5 dash here, 3 dash here, all the codons same, just replace U with T. Easy? Okay, easy. Then we can make the template strand. Now template strand will be complementary to the non-template strand, obviously. So left is 3 dash, right is 5 dash. Now complementary to C is G. For A it is T, C, C, A. Okay. Now our right side is 5 dash, left is 3 dash. So bring this 5 dash to left. A, C, C, T, T, G. So this is 5 dash, this is 3 dash, this is our answer. So answer is A na. This is tricky. See how I have done it. First RNA is given. So you need to take care of direction. Okay. So RNA is given, obviously left is 5 dash. Then non-template is almost same to RNA, just replace U with T. Then template strand of DNA is complementary to non-template strand. So it is 3 dash on left hand side. Now we will bring 5 dash to left hand side. A, C, C, T, T, G. Answer is A. If a question is given, they have given the template strand of DNA, the sequence of template strand of DNA is given, and RNA they are asking, then also you have to follow the same thing. If template strand is given, first make the non-template strand, from non-template make the RNA, and always take care of direction. In the end you have to bring 5 dash to left hand side. You have to bring 5 dash to left hand side. Ask one more question. Okay, let's say DNA template strand is given. Okay, you want to practice the question, right? Let's say in the question DNA template strand is given. T, G, 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 A, C, C. Okay. Suppose this is given and now they are asking RNA in the question. Tell me the answer. Dr. Amit requested for this. This is DNA template strand. I am making non-template strand first. So this is 5 dash, this is 3 dash. Non-template will be complementary. Left is 3 dash. So in front of T, there is A, C, 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 T, G, G. Now I will be making RNA. I have less space. So RNA will be same like non-template strand, just replace T with U. Rest everything same. Now for the answer, bring left side, bring 5 dash to left hand side. So G, G, U, triple C, A. This is the answer. So I repeat, first the question which was given was RNA sequence is given, they are asking template. Okay, so RNA is given, whatever sequence is given, left is 5 dash end. Then non-template is same like RNA, non-template strand of DNA is same like RNA, just replace U with T. Okay, then template strand is complementary to non-template strand. So direction will be left is 3 dash on template. In the end, you have to bring the 5 dash end towards left hand side. So you have to do the shuffling in the last step of that because of the direction, because you have to take care of the direction in such questions. The main point here is that the student is taking care of direction or not, right? Yeah, Dr. Ramat. Okay, then I gave you one more question in which this DNA template is given. Let's say this question is there. DNA template is given. T triple G A double C. So left is 5 dash and right is 3 dash. Non-template will be complementary to the template strand. So left is 3 dash and just write all the complementary sequences. Right? Then from non-template, making RNA is very easy because RNA and non-template strand, they have same direction. They have same codons, just in place of T, now we'll be having U in RNA. So A, triple C, instead of T, there's U, then GG. In the last point, we have to bring the 5-N towards the left-hand side. Okay. So it is GGU triple C A is the answer of this question. Okay. Always follow this sequence, which I have told you. Only then you will come to a right, correct answer. Okay. Don't try to jump the step. You have to do all these steps in proper sequence. Only then you will come to a correct answer. Okay, next question. Refeeding syndrome. What is refeeding syndrome? In fasting or malnutrition, what happens is lipid protein catabolism, insulin suppression has occurred. So when glucose is given, there's increased insulin secretion. There's intracellular shift of phosphate, potassium, and magnesium, leading to hypophosphatemia, hypokalemia, and hypomagnesemia. Phosphate, potassium, and magnesium decreases because they shift into the cell. Then, strict vegetarian usually have B12 deficiency. Okay. Which presents with fatigue, weakness, numbness in extremities, tingling sensation, megaloblastic anemia, decreased total iron binding capacity. Factors which increase iron absorption are vitamin C in amla and lemon, then cysteine, acidic pH. Also learn the factors which decrease iron absorption. They are T, phytates, phosphates, oxalates. Xerophthalmia, follicular hypokeratosis, night blindness, and white spot, you all know. Repeated question, vitamin A deficiency, very easy. Lactose has galactose and glucose, and lactulose has fructose instead of glucose. So lactulose has galactose and fructose. Amino acids required for purines are 3: aspartate, glutamine, glycine. Amino acid required for pyrimidines are aspartate and glutamine. Ammonia is transported from body and brain to liver in the form of glutamine. Again, repeated question. Heme synthesis require which amino acid? Glycine. Heme synthesis require which TCA intermediate? That is succinyl-CoA. Hypophosphatemia, hypokalemia, hypomagnesemia occurs in refeeding syndrome. FMGE July 24, Pellagra, high amino acid urea, and normal 5-hydroxy-indolactic acid occurs in Hartnup disease. Increased 5-hydroxy-indolactic acid occur in carcinoid syndrome. Hyperuricemia and self-mutilation behavior. Repeated question, Leishman syndrome. No cherry red spots in KGF, I told you. Earliest marker to rise in myocardial infarction is ischemia modified albumin. Its peak at 30 minutes, but it's a non-specific marker. Infant with jaundice, cataract, hepatomegaly, Benedict's test positive. Galactosemia, again a repeated question. Lactulose made up of galactose and fructose. Exclusive breastfeeding should be done for 6 months. Polished rice, repeated question. B1 deficiency. Vitamin A, repeated question. Bitot spot. Zellweger is due to defect in peroxisome. Best parameter to diagnose diabetes, HbA1c. Then July 24 exam. Child present with bow legs, knock knees, low serum calcium, low 125 dihydroxycholecalciferol, high urinary phosphate. Diagnosis is rickets, vitamin D deficiency. Which ion channel transporter defect is associated with cystic fibrosis? The CFTR gene mutation. The transporter defect is in chloride. How second messenger act? They modulate the intracellular hormone response. A family slept in a room with stove on. All the 5 persons were found dead next day morning with cherry red skin. The cherry red skin, stove on, it is typically carbon monoxide poisoning. 1-month-old infant cries immediately after breastfeeding. So 1-month-old infant is obviously taking only mother's milk. So there's problem with the milk. diarrhea and vomiting, digestive issues, so there's lactose intolerance. 40-year-old female palmoplantar pigmentation. X-ray spine shows calcification of intervertebral disc. I told you this in Alkaptonuria. FMG July 25. Which vitamin deficiency causes lactic acidosis? B1 deficiency is mainly associated with lactic acidosis because B1 is required for pyruvate dehydrogenase complex link reaction. Polished rice, repeated question, B1 deficiency. HNPCC, repeated question, mismatch repair defect. Eruptive xanthoma. I told you eruptive xanthoma means triglyceride increased. Chylomicron increase. Defect is in lipoprotein lipase. Type 1 hyperlipoproteinemia. For coagulation studies, which colored vacutainer? Blue colored vacutainer. Arachnodactyly, hypermobile joints, high arm span, Marfan syndrome, defect is in fibrillin 1 gene. Non-ketotic hypoglycemia, convulsions, poor feeding after prolonged fasting. Very typical of MSUD deficiency. Do read this topic MSUD deficiency in detail. Neonate patient with lethargy after breastfeeding, bilateral cataract, hepatomegaly. Repeated question on GALT, galactosemia. Von Gog's disease, repeated question, hypoglycemia, ketosis, lactic acidosis, massive hepatomegaly. Macrocytic anemia, increased homocysteine and normal methylmalonic. Repeat question, vitamin B9 deficiency. Enzyme deficient in Fabry disease, alpha galactosidase. So, can you note so many repeated questions are asked? There's a pattern. They're frequently asked topics. So, if you do these PYQs and their related topics, it will help you a lot. Wilson's disease, hepatosplenomegaly, golden brown ring in cornea. The best investigation or gold standard investigation in Wilson's disease is obviously biopsy. To gold standard means very, very confirmatory. So we can see copper present in the liver cells, then obviously will be highly confirmed. So gold standard is liver biopsy for the copper quantification. But investigation of choice if asked, then you will say 24-hour urinary copper, because we don't want to pierce liver of every patient to check Wilson's disease. Okay, so investigation of choice will be just taking urinary sample of the patient. Major intracellular antioxidant if asked, it is glutathione. Amyotrophic lateral sclerosis mutation is in SOD1 gene mutation. Most appropriate management of sickle cell anemia is hydroxyurea, which increase the concentration of HbF, fetal hemoglobin. Because fetal hemoglobin has more oxygen carrying capacity as compared to HbS, sickle cell hemoglobin. Hyperammonemia, raised glutamine, poor feeding, vomiting, lethargy, and orotic aciduria. So all these till now were the general features of hyperammonemia, but when they have written orotic aciduria, then it is OTC defect, second enzyme of urea cycle. I told you it is most common enzyme defect. Old man walking with stick, Genu valgum, in the village of Assam. Increased fluorine in water was found. It is fluorosis because bones are affected, so it is skeletal fluorosis. So the fluorine level must be more than 20 parts per million in the drinking water. Low level of B6, B9, B12. Giving multivitamins did not improve the condition. So the diagnosis is homocysteinemia. Okay, homocysteine is increased. It's not because of vitamin deficiency, it will be because of enzyme deficiency. I told you enzyme is CBS. But the question, the options were about the diagnosis, and one of the best option was homocysteinemia. 8-year-old boy with wrist widening, cupping, symptomatically fine. Plasma vitamin D was low. So what is the immediate management you will do? Will you wait? You will not do anything, or you will give vitamin D supplementation? So obviously when the patient has wrist widening, cupping, okay, and plasma vitamin D is low, so we should give immediately vitamin D. We should not wait even if the patient is symptomatically fine. Catalytic activity of enzyme can be measured by Vmax by Km. Also learn catalytic efficiency or specificity constant is K catalysis divided by Km. The higher the ratio, more efficient the enzyme. That's why the name catalytic efficiency. Osteogenesis imperfecta, kyphoscoliosis and bowing of legs. Question was given. So here type 1 collagen is defective. So this is it with your one-liners. Thank you everybody for listening. Thank you for being there. Thank you for doing so much of hard work to become a doctor and helping others in the future. So best of luck and hats off to all of you for studying 19 subjects. Bye-bye.